Hello everyone. We are going to see about anatomy of TMJ. So coming to the anatomy, the area where the mandible articulate with the temporal bone of the cranium is called temporomandibular joint. The TMJ is found with the mandibular condyle fitting into the mandibular fossa of the temporal bone. Separating these two bones from direct articulation is called the articular disc. So here is a mandibular condyle and it is a mandibular fossa and this is an articular disc. So it can be divided into bony and soft tissue components. The first one is a bony component or temporal bone in the mandible, whereas soft tissue components are articular disc, articular capsule, articular cartilage, retrodiscal tissue, ligaments, and the muscles. We will see one by one. The first one is a temporal bone. A temporal bone has three parts. One is a articular fossa or mandibular fossa. Next one is a articular eminence. And third one is a preglenoid plane. The mandibular fossa is a concave structure. Here you can see it is a concave structure extending from the posterior slope of the articular eminence to the postglenoid process. Whereas the articular eminence is a transverse bone prominence that is continuous across the articular surface mediolaterally, functional component of the TMJ. The preglenoid plane is a flattened area anterior to the articular eminence. So here you can see the articular eminence. Next one is a condyle. A condyle is rounded mediolaterally and convex anteroposteriorly. Here you can see it is rounded mediolaterally and convex anteroposteriorly. From the anterior view to projection, lateral pole and the medial pole. On the medial aspect, below its articular surface is a prominent depression. It's a pterygoid fovea, which is a site of attachment of lateral pterygoid muscles. Next one is the articular cartilage. Articular cartilage have four zones. First one is the articular zone, which withstand the force of the movement, less susceptible to effect of aging, better ability to repair. Whereas the second zone is a proliferative zone. It's a proliferate during the loading. Whereas the third zone is a fibrocartilaginous zone, resistance against the compressive and lateral forces. Whereas the fourth zone is a calcified cartilage zone, an active site for remodeling activity. Coming to the clinical significance, it's a tear or damage to the fibrocartilaginous zone lead to arthroarthritis or degenerative joint diseases. Next one is the articular capsule. The articular capsule is a fibroelastic, highly vascular, highly innervated structure. Laterally zygomatic tubercle, lateral remoglenoid fossa and postglenoid tubercle, whereas medially attached to the medial remoglenoid fossa, spinosphenoid and sphenomandibular ligament, middle meningeal artery, or the structure which is present laterally and medially. Posteriorly, there is a petrotympanic fissure. Coming to the articular disc consists of three borders. One is anterior border, posterior border, and the intermediate zone. Anterior border is 2 mm, whereas the posterior border is 3 mm, and the intermediate zone is 1 mm, and it is a avascular structure. Coming to the retrodiscal tissue, here you can see the retrodiscal tissue in the picture. Articular disc blends with a highly vascular, highly innervated structure, the bilamellar zone involved in the production of synovial fluid. It is divided into superior retrodiscal lamina and the inferior retrodiscal lamina. Here you can see superior retrodiscal lamina and the inferior retrodiscal lamina. Superior retrodiscal lamina is elastic fibers restrain disc movement, whereas the inferior retrodiscal lamina is a collagen fibers check ligament to prevent the extreme rotation of the disc. In relation to the TMJ are skin and the fascia, parotid gland, and the temporal branch of facial nerve. This is the most important relation to the TMJ. Superiorly, there is a middle cranial fossa. Medially means inside the spinosphenoid, carotid sheath, foramen spinosum, and middle meningeal artery. Posteriorly, superficial temporal vessel, auriculotemporal nerve, and the tympanic plate present. Anteriorly, the lateral pterygoid and the masseteric nerve and the artery. The clinical significance are when the inferior lateral pterygoid contracts, the condyle are pulled forward down the articular eminence and the mandible is protruded, whereas the superior lateral pterygoid on contraction, slight anterior and medial force on the disc active during clenching under the of teeth. TMJ works as a class 3 lever, whereas your extraction works as a class 1 lever. A TMJ is a class 3 lever, whereas a fulcrum is your condyle or TMJ. The load is the arch of teeth where the bite is applied. Effort is a masticatory muscles. Synovial fluid. Synovial fluid is a lubricating agent for the temporomandibular joint. Boundary lubrication. When the joint is moved, the synovial fluid is forced from one side to the another side in the cavity inside. Whereas a weeping lubrications, during function of joint, force are created between the articular surface, which drive a small amount of synovial fluid in and out of the articular tissue. Volume of the synovial fluid. In upper compartment, it is 1.2 ml, whereas in the lower compartment, it is a 0.9 ml. Coming to the TMJ ligament, three functional ligament and two axial ligaments are present. Three functional ligament are collateral ligament, capsule ligament, temporomandibular ligament, whereas the two axial ligaments are sphenomandibular ligament and the stylomandibular ligament. The collateral ligament attaches medial and lateral borders of the articular disc to the pole of the condyle. It consists of medial discal ligament and the lateral discal ligament. Okay? Medial discal ligament and the lateral discal ligament. The articular disc attached to the medial and lateral part of the temporomandibular joint. Function restrict the movement of the disc away from the condyle. It will hold the disc in the proper position of the condyle and the passive rotation anteriorly and posteriorly. Whereas the temporomandibular ligament, the temporomandibular ligament is composed of two parts. One is the outer oblique portion and the inner horizontal portion. Oblique portion and the horizontal portion. The outer oblique portion from outer surface of the articular tubercle to the condyle neck, whereas the inner horizontal portion from the outer surface of the articular tubercle to the lateral pole of the condyle. Function. Outer oblique resists excessive dropping of the condyle, whereas the inner horizontal limits the posterior movement of the condyle and the disc. Coming to the sphenomandibular ligament, the stylomandibular ligament. The sphenomandibular ligament arises from the spino-sphenoid bone to the lingula, whereas the stylomandibular ligament arises from the styloid process of the ramus to the mandible. It function limits the excessive protrusive movement of the mandible. Coming to the discomalleolar ligament. A discomalleolar ligament is a Pintos ligament, is a ligament structure connecting the malleus in the tympanic cavity and the articular disc and capsule of the temporomandibular joint. Coming to the muscles of mastication, there are four muscles of mastication. We all know that. First one is a masseter, temporalis, medial pterygoid, and the lateral pterygoid. Coming to the masseter, origin from the zygomatic process of the maxilla and the anterior two-thirds of the lower part of the zygomatic arch. Insertion to the angle of the lower half of the lateral surface of the ramus of the mandible. Whereas a function elevates the mandible and contribute to protrusion. Coming to the temporalis, origin from the lateral aspect of the skull to the full extent of the superior temporal line. Insertion to the anterior border of the coronoid process and ramus of the mandible. Action, elevate the mandible, contribute to the retrusion. Coming to the medial pterygoid. Medial pterygoid origin from the medial surface of the lateral pterygoid plate, whereas the insertion to the inferior portion of the medial surface of the ramus and the angle of the mandible. Action, elevate the mandible and contribute to the protrusion. Whereas a superior lateral pterygoid. Lateral pterygoid divided into superior lateral pterygoid and inferior lateral pterygoid. Superior lateral pterygoid, the lower part of the lateral surface of greater wing of sphenoid. Insert into the neck of the mandibular condyle. Whereas the inferior lateral pterygoid, lateral surface of the lateral pterygoid plate and neck of the mandibular condyle. It helps in stabilize the condyle and disc during the mandibular loading, whereas inferior lateral pterygoid protrude the mandible, contribute to the lateral movement and the mouth opening. So here the diagrammatic representation of temporalis masseter, medial and lateral pterygoid, whereas temporalis masseter helps in masseter medial pterygoid helps in the elevation. Temporalis digastric and genoid helps in the retraction. Digastric, genoid, mylohyoid, lateral pterygoid helps in depression, whereas a lateral pterygoid, masseter medial pterygoid helps in protraction. So innervation of TMJ, branch of the mandibular nerve, provide the afferent innervation by the auriculotemporal nerve. Additional innervation is provided by the deep temporal and the masseteric nerve, whereas the vasculation of TMJ is richly supplied with the middle meningeal artery from the anterior and the internal maxillary artery from the inferior. Other important arteries are deep auricular, anterior tympanic, and ascending pharyngeal arteries. Thank you.